So this is second part of CA vulva. Management of squamous cell carcinoma. Presenting symptom can be of asymptomatic or vulvar pruritus, pain, lump, ulcer, abnormal bleeding or discharge. Many will have a history of vulvar symptom due to underlying lichen sclerosis or HSL lump in the groin to lymph node metastasis. Diagnosis: it should be biopsy to exclude the invasion and biopsy to be done under local anesthesia with Keys biopsy instrument. It can be 3 or 4 mm or with incisional or wedge biopsy, but not to do excisional biopsy even if the lesion is small, as this makes subsequent definitive surgery difficult to plan. So preferred is Keys biopsy or incisional or wedge biopsy, but not to do excisional biopsy. If the diameter of the lesion is 2 cm or less and the stromal invasion is less than or equal to 1 mm, typically to conduct radical local excision of the lesion to assess the maximum depth of invasion. And if no part of the lesion has a depth of invasion greater than 1 mm, then this treatment excision is adequate definite. Investigation: complete digital vaginal and rectal examinations, cervical cytology and colposcopy of the cervix and vagina, because HPV related cancer or SIL can occur in those locations. So colposcopic evaluation of the entire lower genital tract is advisable when the carcinoma of the vulva is in younger patient, that is less than 50 years age, in patient with prior history of HPV associated genital dysplasia, or in patient with multifocal lesion. All of these would suggest that carcinoma of the vulva may be HPV associated and additional HPV associated precancerous lesion or cancer may coexist in the vagina or cervix. Full blood count, biochemical profile, liver profile and HIV testing, chest radiograph to do. CT or MRI examination of the pelvis and groins may be helpful, especially for locally advanced tumor, to detect any enlarged lymph node in the groin or pelvis or erosion into the underlying bone or other metastases. So CT or MRI of the pelvis and groin, mainly MRI is preferred. In addition, CT or MRI could be useful in further treatment planning. PET CT scan is more preferred over CT scan to assess and detect inguinofemoral lymph node involvement, as it also detects metastatic disease in large tumor and in recurrence scenario. Surgical management of vulvar squamous cell carcinoma. Surgical management should be individualized. Microinvasive vulvar cancer, that is stage 1A. For stage 1A, the tumor is less than 2 cm and depth of invasion is less than or equal to 1 mm. So manage is radical wide local excision. Groin node dissection is not required in stage 1A. Early vulva cancer is thus confined to vulva and no suspicious lymph node, either clinically or ultrasound or other radiological assessment. So gold standard is radical local excision of the tumor. This is as effective as radical vulvectomy. Associated pre-invasive disease should also be excised to exclude surgical margin of 1 to 2 cm to achieve negative pathologic margin of at least 3 mm, allowing for shrinkage of the fixed tissue. This is 8 mm actually. Many recurrent vulvar cancer, new tumors that have developed in the surrounding abnormal tissue rather than recurrence due to inadequate margins, tumor-free margin of less than 8 mm, high risk of local recurrence. So pathological margin of 8 mm is required to avoid recurrence. Deep margin of the excision should be up to the inferior fascia of the urogenital diaphragm, and if necessary, the distal part of urethra, distal 1 cm of urethra can be removed to achieve an adequate margin without compromising the urinary continence. With most tumor, primary closure is possible, but consideration should be given to reconstructive surgery for closure of large defect and for maintenance of vaginal function. So after tumor removal, you have to check whether the defect is small one or large one. If small defect, then primary closure is preferred. If large, then reconstructive surgery to be done. And most commonly used flap are VY flap, rhomboid flap, or gluteus maximus myocutaneous flap. Management of the groin node is the most important factor in reducing mortality from early CA vulva, as recurrences in the groin are associated with poor survival, despite using multimodal therapy as rescue treatment. So resection of the primary tumor and assessment of lymph node when necessary through separate incision, not to give same incision, separate incision to give for the tumor and the lymph node. This approach allows better healing compared with the en bloc resection of the vulva and groin. If you give single incision and remove the lymph node and vulval tumor part, then that does not give better healing. Both inguinal and femoral nodes should be removed, as inguinal node dissection alone is associated with a higher incidence of groin recurrence. So groin dissection with post-operative radiation for patient with positive node is superior to groin irradiation. Therefore, in patient with vulvar cancer who require surgical assessment of inguinofemoral lymph node, primary groin radiotherapy should not be substituted for surgery. Instead, surgery followed by adjuvant radiotherapy as indicated is our recommendation. Less than 1% of patients who have small lateral lesion, that is less than 4 cm and more than 2 cm from the vulval midline, and negative ipsilateral node have metastasis in the contralateral groin node. Ipsilateral groin dissection is adequate treatment for these patients. Indication of bilateral groin node dissection. Patients who have tumors close to midline, that is up to less than 2 cm. If within 2 cm there is tumor, then bilateral groin node dissection to do, and crossing the midline, especially those involving the anterior labia minora and have very large tumor more than 4 cm or positive ipsilateral node. So indication are patient who have tumors close to midline, that is within 2 cm, crossing the midline, or those involving anterior labia minora or large lateral tumor of more than 4 cm or positive ipsilateral node. Groins 5 study. It is a European multi-center observational study, and aim of the procedure is to detect nodal metastasis in sentinel lymph node. On 403 women patients, this study has been done. Groin recurrence occurred in 2.3% with a median follow-up of 35 months. Disease-specific survival was 97% after 3 years, and surgical morbidity was substantially reduced. So indication of sentinel node procedure as per the groin study. Unifocal tumor confined to the vulva, tumor less than 4 cm, because more than 4 cm you have to do bilateral groin node dissection. Stromal invasion more than 1 mm, because in less than 1 mm there is no role of groin node dissection. Clinically and radiologically negative groin node, those are candidate for sentinel node procedure. First is unifocal tumor less than 4 cm, stromal invasion more than 1 mm, and clinically and radiologically negative groin nodes. Sentinel lymph nodes are identified using both radio-labeled technetium and blue dye. Recently, ICG dye with near infrared fluorescent technology has become an option for sentinel node detection. Of note, when an ipsilateral sentinel lymph node is not detected, a complete ipsilateral inguinofemoral lymphadenectomy must be performed. If an ipsilateral sentinel lymph node is positive, then a complete bilateral inguinofemoral lymphadenectomy is recommended. Patients with one small lymph node metastasis appear to have a good prognosis after lymphadenectomy alone, unless there is extracapsular spread, and these women do not appear to benefit from the adjuvant radiation. So one small lymph node metastasis have good prognosis, and those don't require adjuvant radiation. Indication for pelvic and groin irradiation in patient with positive groin node when there is presence of extracapsular spread or 2 or more positive groin node or inadequate dissection. If these three, any of the present, then you have to give RT therapy, radiation therapy. All patients who have isolated tumor cell or micrometastasis on sentinel lymph node biopsy do not need any more surgery and can be managed by adjuvant radiotherapy. Patients with macrometastasis need full inguinofemoral lymph node dissection followed by adjuvant radiotherapy to the groins and pelvis if indicated. Groins B2 investigated the efficacy of groin radiation without lymphadenectomy for patients with positive sentinel lymph node. Increase in groin lymph node recurrence in cases with sentinel lymph node micrometastasis greater than 2 mm or extranodal extension. After the protocol was amended, adjuvant radiotherapy was given to patient with sentinel lymph node metastasis up to 2 mm, that is micrometastasis, whereas inguinofemoral lymphadenectomy was performed in cases with sentinel metastasis exceeding 2 mm or extranodal extension. The updated results showed that the groin recurrence rate for micrometastasis 1.6% for radiotherapy group versus 11.8% without radiotherapy group. So patient with isolated tumor cell treated with radiotherapy had no recurrence, whereas there was one groin recurrence, that is crude relapse rate of 9% in one ITC patient who did not undergo radiotherapy or surgery. For macrometastasis, the groin recurrence rate for radiotherapy group was 2% versus 96% in the surgery or radiotherapy group. So vulvar cancer up to 4 cm in size with sentinel lymph node metastasis up to 2 mm groin radiotherapy is given. For macrometastasis, surgery followed by adjuvant radiotherapy is given. Radiotherapy, radiation of field during adjuvant external beam radiotherapy generally include bilateral inguinofemoral and external and internal iliac lymph node in most patients. However, groins B2 allowed ipsilateral radiotherapy, especially if contralateral sentinel lymph node was negative for malignancy or if the lesion was well lateralized. If there are many or bulky positive inguinal node or if pelvic node metastases are suspected, the upper border of the radiation field might be extended to include entire common iliac node region. The treatment of the primary surgical bed in this situation is optional based on risk factor like LBSI, margin status and tumor size. Intensity modulated radiotherapy is preferred because of its significant dosimetric advantage, sparing the rectum, bladder, bowel loop, femoral head, uninvolved skin, and improve the treatment tolerance. It reduces morbidity compared to historical data. Radiation dose is determined by the initial extent of disease and any known residual. After a groin lymphadenectomy, where microscopic inguinal metastases are found, 50 gray in 1.8 to 2 gray per fractions are usually sufficient. In case of extracapsular spread, the radiation dose up to 60 gray can be given to a reduced volume. Gross residual disease usually requires 60 to 70 gray to achieve a high likelihood of regional disease control, and women with node positive vulvar cancer benefited the most from the addition of chemotherapy to adjuvant radiation. Advanced vulvar cancer, it includes tumors that extend beyond the vulva and where there are bulky positive groin node, so FNAC or biopsy of the node to be done, and pelvic CT, MRI or PET CT to know the extent of inguinal and pelvic lymphadenopathy and the presence of distant metastatic disease. If there are no suspicious nodes, either clinically or on imaging, bilateral inguinofemoral lymphadenectomy may be performed. If the nodes are negative, radiotherapy to the groins and pelvic nodes will not be necessary. However, if the histology reveals positive node, then adjuvant radiotherapy or chemoradiotherapy to the groin and pelvis should be offered along with treatment of the primary tumor. An alternative approach is to treat pelvic and groin nodal regions prophylactically, rather than tailoring radiation field based on dissection fielding. Whether the risk of lymphedema, groin wound complication and quality of life is better with upfront inguinal lymph node dissection or primary prophylactic inguinal and pelvic nodal radiation in this patient with clinically and radiologically node-negative disease remains to be evaluated in a prospective study. In cases where surgery is thought to be inappropriate for the individual patient, primary chemoradiation may be used to treat the primary tumor as well as groin and pelvic node. Ulcerated or fixed groin lymph nodes should be biopsied to confirm the diagnosis and then treated with primary radiotherapy, with or without chemosensitization. If there is incomplete response to radiation, the nodes may then be resected if appropriate. An alternative strategy is the use of NSAT with cisplatin or carboplatin and paclitaxel to shrink the nodes before radiotherapy. For management with primary tumor, surgical excision with clear margin whenever possible remains the optimal treatment for advanced CA vulva. If adequate excision of the primary tumor can only be achieved by exenteration and the formation of a bowel or urinary stoma may be preferred treatment alternative. Local control may be improved if any post-radiation residual tumor is resected. Concurrent chemoradiation is a well-described treatment alternative for those patients with large tumors in whom primary surgical resection would damage the central structure like anus, urethra, and long-term complete responses have been reported. The groin nodes and pelvis may need to be included in the radiation field depending on the status of the groin nodes. Neoadjuvant treatment with cisplatin and 5-fluorouracil or other chemotherapy combination effective for the preservation of the anal sphincter or urethra in patients with advanced CA vulva. Radiation treatment field should include the pelvis, inguinal node and the vulva. This should be treated with a total dose of at least 50 gray with attention to adequate coverage of the inguinal node. Gross disease or high risk area may be boosted to the dose up to 60 to 70 to achieve local control. Targeted therapy in CA vulva. Possible targets in HPV associated cancer may be the E6 and E7 HPV oncogenes, as with therapeutic vaccines as well as immune based therapies, while mutation in non-HPV associated cancers such as PI3K, CDKN2A and TN may be effective target for treatment. Inhibition of EGFR has been successfully utilized and published for vulval cancer. In a phase 2 study, erlotinib, that is an EGFR inhibitor, showed a clinical benefit rate of 67% in women with metastatic vulval cancer. Keynote 158 examined the efficacy of pembrolizumab in women with metastatic vulval cancer. The overall response rate was 10.9%, 9.5% in women with PD-L1 positive tumor, and 28% in women with PD-L1 negative tumor. Median progression-free survival was 2.1 months and overall survival was 6.2 months. Checkmate 358 examined the use of nivolumab in a woman with HPV-associated cancer. There was a 20% overall response rate and 80% disease control rate for CA vulva or vagina. In summary, targeted therapy are feasible in metastatic vulval cancer and are being investigated. Current data support the use of EGFR inhibitor like erlotinib as well as immune checkpoint inhibitor like pembrolizumab, nivolumab, regardless of the PD-L1 expression in patient with metastatic vulval cancer. Closed surgical margin. Most CA vulva recurrence occur on the vulva. It is thought that surgeons should aim for tumor-free pathological margin of 8 mm or more to minimize local disease recurrence. Local recurrence in patient with primary vulvar carcinoma are associated with DVAN at the pathological margin rather than the tumor-free margin distance. Recurrent disease. Managing recurrent disease is often difficult with treatment option depending on the site of recurrence, patient performance status, prior treatment received, and restaging findings. Options for treatment include surgery, chemoradiation, neoadjuvant or palliative chemotherapy, or targeted agent. Follow-up. Local recurrence most often occur within the first 2 years after treatment. Most often with gynecological malignancy are seen in every 3 to 6 months for the first 2 years and then every 6 to 12 months until they are 5 years post-treatment. All patients should be followed annually for life beyond 5 years because remote site recurrence and new primary cancer may occur many years later. The surveillance visit should include a review of symptoms relevant to recurrence or adverse effect of treatment and thorough clinical examination. Elevated pre-treatment serum concentration of squamous cell carcinoma antigen may serve as an independent prognostic factor for disease-free and overall survival in patients with vulvar cancer. For a select group of patients, squamous cell cancer antigen may be useful as a serum tumor marker for surveillance. All women who have vulvar cancer should be offered psychosexual counseling and support before, during, and after their treatment. Rare vulvar malignancies. Vulvar melanoma. It is the second most common vulvar malignancy after squamous cell carcinoma. Although it is a very rare tumor with an incidence of 1 in 1 lakh patient. Mucosal melanomas found on the vulva and in the vagina have a poor prognosis with a 15% only 5-year survival. Their cause and genetics differ from the cutaneous melanomas. Any pigmented vulvar lesion should be biopsied or excised for diagnosis unless it has been present and unchanged for some time. The majority of vulvar melanoma involve the clitoris and labia minora. It does not follow the FIGO staging. So AJCC system with the Clark or Breslow modification of the staging system is used in vulvar melanoma. Treatment of choice is the surgery and it should be treated by radical local excision with margin of at least 1 cm. The current trend leans towards more conservative resection of vulvar melanoma because no survival difference has been noted in patient undergoing local excision versus with radical vulvectomy. So conservative surgery is preferred. The role of lymph node dissection is controversial. Till date, no overall survival advantage has been done for inguinal lymphadenectomy. However, some trial compare elective node dissection with observation for intermediate thickness cutaneous melanomas 1 to 4 mm showed significantly better survival in patient aged 60 years or younger, those with tumor of 1 to 2 mm thick, and those without tumor ulceration. It remains important, however, to remove any lymph node that are clinically or radiologically involved with tumor. If it is involved by the tumor, then you have to remove the lymph node. Sentinel lymph node evaluation has been explored for vulvar melanoma. Although it is feasible, a false negative rate of 15% has been reported. So it has been suggested that the procedure may increase the risk of locoregional recurrence. So it is not currently standard of care. And the melanoma focus guideline does not recommend the use of sentinel lymph node procedure outside the clinical trial. Vulvar melanoma should be tested for c-KIT and BRAF mutation as there may be a role of immunotherapy such as nivolumab. Bartholin gland cancer. Bartholin gland cancer are a rare form of vulvar malignancy accounting for approximately 5% of vulvar cancer. It is unclear what proportion is associated with high-risk HPV infection. Cancer of the Bartholin gland may be either transitional cell or squamous cell carcinoma that arise from the duct, or adenocarcinoma arising from the gland itself. There are also adenoid cystic and adenosquamous variants. All squamous cell carcinoma shows diffuse and intense P16 expression consistent with the presence of HPV. The diagnosis is often made after resection of a persistent or recurrent Bartholin cyst. Bartholin gland carcinoma are effectively treated with radical hemivalvectomy and bilateral groin dissection. However, they are more likely to have metastatic disease at presentation. Due to their location deep in the ischiocrectal fossa, adequate surgical margin may be difficult to achieve, and postoperative radiation may decrease the likelihood of local recurrence. Radical local excision alone is adequate treatment for adenoid cystic lesions, and adjuvant radiation is recommended for positive margin or perineural invasion. Paget's disease of vulva is known as extramammary Paget's disease. It is a rare intraepithelial adenocarcinoma arising from the apocrine gland bearing skin like vulva, perianal area, perineum, scrotum. It occurs mainly in the postmenopausal women. Two types of extramammary Paget's disease, that is vulvar Paget's disease. Primary form begins as an intraepithelial lesion, and secondary form, which is due to invasion from an underlying adenocarcinoma and may be an anorectal, urothelial or genital tract carcinoma. Vulvar Paget's disease predominantly in the postmenopausal women group. It presents with vulvar pruritus and pain. On examination, there is a exhumated weeping lesion. Diagnosis is usually confirmed by biopsy, which also help to differentiate between an intraepithelial and an invasive lesion. Treatment of choice is wide local excision. It is challenging to achieve clear margin, as histological changes often extend far beyond what is visible macroscopically. Even with adequate margin, recurrence rates are high. Due to high recurrence rate and surgical morbidity, there is a current move to perform less radical resection for intraepithelial lesions, with re-excision at a later date. Lesions involving the urethra or anus also present a management challenge and may require laser therapy. Another conservative option is the local imiquimod. If an underlying adenocarcinoma is present, treatment should be radical local excision with margin of at least 1 cm. Inguinofemoral lymphadenectomy should be performed with adjuvant radiation for the same indication as per squamous carcinomas. Women with Paget's disease of vulva should have long-term follow-up in a specialist vulvar clinic. Pathology considerations. Specimen analysis. Correct orientation of the surgical specimen is important. Photographs. This should be taken of the whole specimen as well as the origin of each tissue block. Measurement. Size of the specimen, dimension of any visible tumor, macroscopic tumor-free margin and tumor depth. Section taken through the tumor. Sections should also be taken from urethral, anal and vaginal resection margins. Lymph nodes. These should be dissected out, the side from which they are removed recorded, and a full cross-section of each lymph node should be embedded. The following histologic points should be noted: tumor type, depth of invasion, tumor grade, histological measurement of tumor-free margins, and statement as to whether tumor is completely excised or not. Presence or absence of perineural or vascular space invasion, nature of the adjacent squamous epithelium, including DBIN and lichen sclerosis and HPV associated changes to be noted. ISA testing of P16 and P53 is recommended. Sites and number of nodes examined, number of positive nodes, and presence or absence of extracapsular extension to be noted. Thank you.